Thanks.
So after finishing her PhD thesis at the Department of Virology and the University of Turku, Finland, Heidi specialised in clinical biochemistry at the Turku University Hospital Laboratory with close to 10 years of experience as a clinical biochemist. She started working for Lab Quality, a Finnish service company focused on quality assurance of medical laboratories and point-of-care testing, as the EQA developing manager in 2018. Heidi's responsibility is to follow the trends in the fields of laboratory medicine and to manage new EQA projects. Developing new kinds of service from end-to-end quality assessment requires multidisciplinary knowledge, and Heidi finds it motivating to search for suitable, commutable sample material and to interact with experts in the field. The main goal is, of course, to improve patient safety. Heidi, the floor is yours. Thank you.
Thank you so much for the kind introduction. And I would also like to thank all the organizers and also our colleagues at EQA for inviting Lab Quality to give a presentation here at your very interesting event. It's really my pleasure to tell you about the pandemic situation from an external quality assurance provider's point of view. As for all of you, the spring was very busy at Lab Quality, and we worked very intensively to respond to this sudden need of proficiency testing for this new coronavirus. I don't know if you're familiar with Lab Quality, so just as an introduction, I would like to say a few words about who we are. Lab Quality is an independent Finnish service organization focusing on enhancing patient safety. On this slide, you can see all our lines of action. I would just like to point out two of them. On the very right-hand side, you can see our traditional and largest focus, which is in providing EQA schemes for medical laboratories and point-of-care sites. And next to it, you can find our newest branch of activities, which is in medical device registrations. We have clients in 55 different countries all over the world, and a total of about 7,000 clients. In addition to our staff of about 60 persons, we cooperate closely with a network of 200 experts, of which just over 100 are our scheme experts, whose names you can see on the final reports on our EQA rounds. We have about 170 products in our EQA portfolio, and we aim to cover the whole laboratory process all the way from the pre-analytics to the analysis phase and also post-analytics. Our goal is to produce clinically relevant EQA schemes, and therefore we eagerly listen to the needs of our clients, to our partners. We perform different surveys and we attend meetings and congresses, and we are open for new ideas. And what you can see here is the typical lifespan of an EQA development project. When we start working on a new scheme, the process typically takes about 1 to 1.5 years before we are ready to include it in our EQA program. We evaluate it always thoroughly, we discuss it in our expert groups, and we put a lot of effort in finding suitable samples which should be as commutable as possible. In most cases, we also plan and perform a pilot study, and based on all of these evaluations, we then make the decision on including the new scheme to our program. And after running the scheme for a few rounds, we aim to include it in our accreditation. So our EQA service is accredited to the ISO 17043 standard. But this spring, the situation was very different. We were in a different situation when we were contacted by both partners and clients directly, and we were asked if we have an EQA scheme for this new virus, which is actually, it was only named a few weeks earlier. So there was really no time for us to be considering and evaluating this EQA scheme for a year, as we usually do, since the clients really needed it immediately, and especially with announcements of new diagnostic methods dropping in almost on a weekly basis. So we found that an EQA program for COVID-19 should be our top priority. So what we did is that we really had to fast forward our development process. The most urgent need was for nucleic acid testing, but there were also discussions about serological tests, so we started working on finding sample material for both test types. We cooperate closely with several sample manufacturers, so we reached out to them about samples. But we also had another concern, and that was about evaluating the sample material offered to us. Regarding evaluation of samples, we cooperate closely with the university hospital laboratories in Finland, And at this point, they were extremely busy setting up their COVID-19 diagnostics and expanding it to meet the demands of the increasing number of patient samples, as we just heard in the previous talk. So we addressed 2 of these laboratories, and we were very, very glad that they also saw the importance of EQA in this very hectic time. And they agreed to run our evaluation samples. So basically, we did all these steps here in the middle just at once, and the whole process was about 2 months when we were ready to launch our pilot study. At this moment, these schemes are not yet included in our accreditation, but this is the aim we have to include them later on. So when we had received the first preliminary evaluation results of the sample material, we then announced our new EQA program for COVID-19 on April 24th. It included individual samples for molecular diagnostics and serological testing, with the option of ordering either one or both sample types depending on the need of the laboratory. The first rounds were offered as pilots free of charge, and we thought this would be our way of supporting the work in trying to master this pandemic situation. We were not the first EQA organization to announce a scheme for the nucleic acid testing, so we thought that we might not maybe have that many participants on the pilot, but however, we were very wrong in making this assumption. We had made a preliminary order of 50 sample sets from the sample manufacturer, but fortunately, we could increase our order to 160 sample sets. But still, we were sold out in less than a week. There would have been lots of more participants joining the pilot study, and we're very sorry that we were not able to include all of them. But instead, we decided to set up the following rounds for September and November. And this screenshot here is actually from our web page. The criteria for the sample material for the nucleic acid detection pilot was, of course, that the material should be safe, it needed to be stable, and it needed to be suitable for many different platforms. So for the nucleic acid detection pilot, we had 1 positive sample containing human fibroblast cells and SARS-CoV-2 whole genome cDNA desiccated on a swab, and we had a negative sample containing fibroblast cells only. Our 2 expert laboratories, as well as a diagnostic company, Mobidiag, they evaluated the samples for us on several different platforms. And as the reference result on the pilot, we used the results by the in-house e-gene-specific RT-PCR test recommended by WHO. For the antibody detection pilot, it was actually even more difficult to find samples. And the limiting factor for participation was that we were not able to retrieve large amounts of one or single donor samples in the desired schedule. We had a single donor SARS-CoV-2 antibody positive sera from a Finnish donor, and this was enough for 130 participants. We were then able to retrieve a sample from a second donor, so we then quickly set up a second antibody round since there were more participants in line. And before the distribution date of this second pilot study, we were actually able to retrieve a sample material from a commercial partner, so we had 2 positive samples included in the second pilot study, antibody pilot study, that is. So by doing this, we were able to include roughly 170 participants for the antibody pilot studies. And what you see here is a slide, it's a screenshot from our result report in our digital EQA portal called LabScala. There's a lot of more detailed information available in LabScala presented visually in different ways, both regarding the laboratory-specific results and the global results, but due to the limited time here, I will only show you the overall results. So these are the overall results of the nucleic acid detection pilot. From here you can see that we distributed the samples to 157 participants, of which 142 respondents, so that gives us a response rate of 90%. Several participants responded with 2 or 3 different methods, and thereby the total number of responses was 194. We had participants from 23 different countries, and they used together more than 40 different methods or assays. So the expected result here from sample 003 was negative, and there were 2 false positive results reported. So this gives us a success rate of 98.4%. Included in this number is also the results for 1 laboratory that had interchanged the samples by mistake. Without this interchange of samples, the success rate of the positive sample 004 would have been 100%, but now it was 99.5%. However, this average success rate on this round was thereby an excellent 99%. This is a qualitative round where scoring was done only on the qualitative results, positive or negative. However, there was the option of responding also CT values and to give a clinical interpretation, but these were not scored, and I will not go into the details here. I will then show you the combined results for both antibody pilots. So we had a total of 174 participants from 23 different countries, and the response rate was 80%. There was the possibility to respond to total antibodies or specific IgG, IgM, or IgA antibodies. And in addition, we also had separate groups for point-of-care tests. Again, we had many participants responding with several different, several different results, and the total number of responses was thereby 385 with some 60 different methods or assays. So the average success rate for the 2 negative samples was an excellent 99%. On the first round, there were 2 false positive results reported, 1 for total antibodies and 1 for an IgG assay, and these were actually reported by the same participant. On the second round, there was only 1 false positive result. It was on a point-of-care IgG-IgM test. So looking at the positive samples, we had an average success rate for altogether 3 positive samples of 97%. Based on these results, it seemed that IgM is the most, or is the analyte causing the most deviations in the results. So this was just a brief summary about the results, and I want to just show you the timeline of how we were able to pull these pilot studies through in the spring. So we received the first requests for a pilot study or for an EQA in March, and then we announced the pilots in April, and the samples were distributed at the end of May, and for the second antibody pilot on June 1st. We typically, our rounds are open for about 3 weeks, and after evaluating the results, the reports were published to the clients in the beginning of July. Then the first non-pilot rounds for both nucleic acid detection and antibody detection were distributed in September, and our experts now have the results for evaluating and for commenting. So, and then both of these rounds will also be distributed in November and 4 times next year. But our work on COVID-19 did not stop here, and I'm very glad to be able to tell you that we will be conducting a SARS-CoV-2 antigen pilot study in November, and also this scheme is included in our program for 2021. So in 2021, we have 3 schemes for SARS-CoV-2 virus in our program. In the printed catalog that was published already in September, the antigen scheme is announced as a pilot, but please note that, as I mentioned, the pilot will be conducted already this fall, and we will have all 3 products available 4 times in next year. The first rounds for all of these 3 schemes will be distributed in January, so please register shortly if you are interested in participating. I would like to acknowledge the people involved in this project. Our scheme experts, Adjunct Professor Matti Varis from the Turku University Hospital Laboratory in Finland, and clinical microbiologist Vesa Mäntynen from the Oulu University Hospital Laboratory Nordlab. They were of a tremendous help in evaluating the samples with us for both pilot studies and also for commenting the results. And they will both be acting as our scheme experts on the coming rounds as well. At Lab Quality, people from several different teams were involved in addition to our product development team. And all of this work was done during a period when we had just moved from working at the office to be working at our home offices. So this brought some, how should I say, extra spice to this project. I do want to especially thank Marisa Järvenpää, who is the EQA coordinator for our COVID-19 schemes. She really deserves a thank you for her commitment to this project. And finally, I would like to tell you that, like so many other events this year, we had to cancel the annual International Congress on Quality in Laboratory Medicine Lab Quality Days. It would have been taking place in February of 2021. But we are very happy to say and to tell you that the full scientific program has been postponed with 1 year to February of 2022. So please have a look at the Congress program on our webpage. We have some very distinguished speakers and they have all agreed to join us in 2022. So let's hope that the situation will be better then and it will allow us all to meet in Helsinki. If you have any questions later on, or if you have any needs for EQA rounds, please feel free to contact me by email. You can see my email address here below. And with this slide, I would just like to thank you all for your attention. Thank you.